So let us start with our next part of pre-surgical infant orthopedics, PSIO, or it is also known as nasoalveolar molding or neonatal orthopedics. Okay, so pre-surgical infant orthopedics is a procedure in which maxillary alveolar and nasal tissues in cleft lip and palate are affected children is molded into a favorable position so as to achieve a more accurate post-surgical result. Okay, once again, it is a procedure by which the maxillary, alveolar and the nasal tissue in cleft lip and palate patients is molded into a favorable position so as to achieve a more accurate post-surgical result. What are the advantages? It reduces the cleft gap therapy, avoiding two-stage cilioplasty, that is the lip surgery. Pre-surgical infant orthopedics molds the growth of the alveolar segments, thereby providing a controlled and a planned arch form. It favors nasal correction, thereby reduces the number of surgeries. The smaller the cleft gap, the favorable is the healing process. Need for secondary alveolar bone graft can also be reduced. It also favors the lengthening of the columella, particularly in bilateral cleft lip and palate patients. Once again, reduces the cleft gap, thereby avoiding tooth cilioplasty. Pre-surgical infant orthopedics molds the growth of the alveolar segment, provides a controlled and planned arch form, favors the nasal correction, reduces the number of surgeries. So the smaller the cleft gap, the faster is the healing. Need for secondary alveolar bone graft is also reduced. It also favors lengthening of columella, particularly in bilateral cleft lip and palate patients. Okay, so the pre-surgical nasoalveolar molding should be done or completed before the 6 months or significantly before the 1 month of age. Why? Because in the first 6 weeks of life there is an increased level of maternal estrogen in the circulation. This estrogen helps gives an increased hyaluronic acid. This hyaluronic acid breakdowns in the intracellular matrix and alters the elasticity of the cartilage. This brings out the desired results which are permanent. Once again, in the first 6 weeks of life, there is an increased estrogen in the blood circulation of the neonate. This estrogen increases the availability of hyaluronic acid. Hyaluronic acid breaks down in matrix and it provides more elasticity to the cartilage. Therefore, it brings about the desired result which are permanent. Now these appliances can be active appliance, that is these appliance apply control force to bring out desired relationship between the cleft segments, or they can be passive appliance, that is they do not apply any force to bring about the desired result by guiding the growing segments. Now what are the steps in nasoalveolar molding? Newborn should be evaluated within 1 to 2 weeks of birth and assessment is made. If pre-surgical nasoalveolar molding is indicated, parental acceptance of PNAM and compliances are determined at this stage. Now what are the procedure? In the first step, suction apparatus and oxygen should be available for the emergency airway support. Okay, suction apparatus and oxygen are very important for this process. If any emergency condition is there, we should have a backup. The baby should be positioned with the head up. A non-custom stock tray or prefabricated special tray should be checked for fit. This you can see, these are the non-custom stock tray or prefabricated special tray. Now heavy body silicone putty, this should be used so that to prevent the gag reflex. Putty impression material is then mixed and an impression of the palate and cleft alveolus is taken. The impression material is allowed to flow adequately. Once the impression material is set, the tray should be removed and the mouth is examined for any residual impression material. The cast or the model of the alveolar anatomy is made with the dental stone. The PNAM outline is marked on the cast and a molding plate is fabricated either with a hard clear acrylic or thermoformed silicone acrylic material. You can show this is what this is a silicone acrylic material. Okay, now It is then inserted and is secured extraorally to the cheeks with the surgical tapes or elastic loops. These tapes are changed daily. These are the surgical tapes, as you can see. Parents are instructed to keep the plate in full time and remove only for cleaning. The plates are modified weekly. When the cleft alveolus is reduced 5 mm or less, nasal stent is added. The stent is made up of 0.036 gauge round stainless steel wire and takes the shape of a swan neck. You can see these are the nasal stent. These are used in cases of bilateral cases, and it has got a modified into swan neck. Can you see? It is made up of 0.036 gauge stainless steel wire. The primary lip repair is performed from 3 to 6 months of age. 3 to 6 months of age. Again, number one, in the beginning, the evaluation should be done within 1 to 2 weeks of the birth, and assessment should be done. Parental acceptance and compliance should be determined. Now, first of all, what you should keep ready: suction and oxygen apparatus for emergency condition. It should be ready. Baby should be positioned with the head up position, and non custom made stock tray or prefabricated special trays we need. Then heavy body silicone material is mixed, and impression of the palate and cleft alveolus is taken. Impression is allowed to flow adequately. Once the impression material is set, remove it from the mouth. Check for any residual impression material. Then a cast or model of the alveolar anatomy is made with the dental stone. Cast is formed. Then the outline is marked on the cast, and a molding plate is fabricated using a hard acrylic or silicon thermoform silicon acrylic material. Then it is inserted and secured extraorally using the surgical tapes or elastic loops, which is continuously changed. Parents are instructed to keep the plate daily, all the time, except should be removed only for cleaning. The plates are modified weekly. Once the cleft alveolus is reduced to 5 mm or less, nasal stent is added. When it is reduced to 5 mm, remember this, or less, nasal stent is added. Nasal stent is made up of 0.036 gauge round stainless steel wire. It takes the shape of a swan neck. It helps in the retention and gives proper nasal nasal molding. Primary lip repair should be performed from 3 to 6 months of the age. There were various controversies associated with the pre-surgical infant orthopedics. The controversies exhibits that there were two schools of thoughts. The large case control studies, particularly being treated with Lantham-Millard technique, have demonstrated adverse effects on the future outcome. Adverse effects were seen in that Berkowitz et al. In 2004 reported more cases with anterior crossbites in cases treated with Lantham-Millard device. Similar findings were observed in Matic and Power 2008 with the use of active appliance therapy. However, the use of passive nasoalveolar molding with gingiva perioplasty has shown favorable results, as seen by Grayson 1997 and Santiago 1998. Hence, it can be concluded that performing nasoalveolar molding with a passive appliance therapy would not have any adverse effects on the maxillary growth. So, active appliance, who has done the study, you can active appliance according to Berkowitz, Berkowitz, Berkowitz in 2004, and Matic and Power 2008. They have shown that there was unfavorable outcomes. With PSIO. Sorry, this is PSIO plus active appliance. Then another study was done by Grayson, which concluded that PSIO plus passive appliance showed favorable outcome. Grayson in 1997. Okay, so here we can conclude our pre-surgical nasoalveolar molding. I hope there is no confusion about it. If any questions you guys are having, I'll be happy to answer you. You can post it in your comment section. Thank you so much.